the mandible, not the soft tissue. We're not going to hyperextend, we're just going to tilt the head back and clear the airway. If there were a cervical spine injury or we anticipated some kind of problem with the head, we could use this jaw thrust technique. And here we fit the hands like an E at the angle of the mandible and push it forward and the jaw down and forward to open into like a class 3 position to open the airway. Now, what are some of the potential causes of an airway obstruction? Well, the tongue, dentures, food, vomit, blood, or secretion. Cotton rolls in our case. So, we're going to take our suction. We're going to try and clear the airway with our suction. We can use our choking protocol, abdominal thrust, the Heimlich maneuver, if something's been lodged. And if it's unsuccessful, we're going to start basic life support, chest compression, and activating our EMS system. Now, part of this oxygen unit has to be a mask, a face mask to deliver, or a nasal mask to deliver the oxygen. Once we get the airway open, we're going to place the oxygen. And a simple face mask is a plastic device that's contoured to fit over the nose and mouth, and it's used to deliver oxygen as the patient breathes, either through the nose or through the mouth, and it has side ports that mix the air. It has no reservoir or bag attached to it, and it can deliver up to 60% concentration. Now remember that room air is only 21%, so this is high saturated oxygen. And we deliver it at a rate of somewhere between 6 and 15 liters per minute, depending on the patient's size and respiratory volume. It looks like this. And there's these little side ports. And that mixes room air with the oxygen we're delivering that is hooked up right to this little gasket. And the band fits around the head. So if the patient's having respiratory distress, we put this on, they start to feel better, we can maybe turn it down, but leave it on, let them totally come back. Or we can deliver it by a nasal cannula. Now the nasal cannula is going to fit up into the nostril, and the percent of oxygen delivered is room air, because they're breathing through their mouth and nose normally, 21%, plus this 4% oxygen for each liter. So if we use 4 liters and 4%, we would add 16% oxygen to normal room air, giving us a tidal volume there of 37%. And that works well. Somebody is just feeling a little faint, doesn't want the mask on, they feel close claustrophobia. You can use the little nasal cannulas. But you have to know what's available in your office, how it works, what sizes you have, because the last thing you want to do when someone's having a problem is be fumbling with equipment, because the patient's going to perceive you were not prepared for this emergency. And if it doesn't go as well as they would have appreciated, that could be a problem for you. You have to be prepared. So the little nasal cannula has these prongs that fit in, and then this is attached into the port. Now this is a concept that if you deliver too high a dose of oxygen, that the patient may stop breathing on their own and may need assisted, positively pressurized if you gave too high a dose of oxygen. Now, whether or not that's going to occur, I don't know, but if you notice people that have been long-term smokers, their body is operating all the time with carbon dioxide overload. They're gummed up in their arteries. And there is the thought that if you have chronic obstructive pulmonary disease, that what's driving you is not the percentage of carbon dioxide in your blood, but the percentage of oxygen. And we have sensors for both. And the thought is, if we gave 100% oxygen to someone, maybe they'd just stop breathing because they're not used to having 100% and they think they don't need to breathe anymore. And so they make masks that accommodate that. Whether or not it's accurate or not, the masks are made. And so because the masks are made, sometimes we see these masks and we don't know how to use them, or we feel they're not working properly. And so I'm including them here because I don't know the kind of equipment you have in your particular office. But a partial rebreather mask is very similar to the oxygen mask, the simple oxygen mask I just showed you. But the mask is called a partial rebreather because it has a plastic reservoir bag attached to it, which takes some of the expired air of the patient and preserves it. So when they inhale, they're inhaling some of that carbon dioxide too, to keep this respiratory drive alive, right? It has little side ports as well, but they have one-way valves that let some of it go out and some of it go into this bag. Now, when we see these, bags, this little bag here that's attached, oftentimes we think it should fill up, be like a balloon with oxygen. And so when you put that on, you think, oh my gosh, my oxygen's not running because my balloon has not filled up. But you don't have to be worried about that. That balloon filling or not filling doesn't have anything to do with your oxygen. Your oxygen's working just fine, okay? So that's why I'm including that little slide here, because I don't know the equipment you have in your office, but if it would be a mask that has that balloon attached, it's insignificant to what you're going to be doing, okay? Now, what if somebody has a laryngectomy? How do we handle that? Well, sometimes the breathing tube might be attached right to it, okay? And we can attach into that breathing tube. If it's obstructed, we need to suction it out. You know, there might be some mucus in there, right? If some patients may have a partial laryngectomy, and so we have to cover their face and mask if we're going to deliver oxygen into the laryngectomy, because it'll escape through the nose. And so we want to make sure that we keep that clear. And how about kids? What do we do with kids? Well, if a child's having a problem, we don't want to hyperextend the neck like we would put the forehead and the chin. We want to keep them more in a neutral position, just maybe a little bit open. We want to watch for gastric distension if we would be ventilating a child, because a child's windpipe very easily, they can get a stick on you. If we had any facial injuries, because there's a rich blood supply to the face, or blunt injuries will cause swelling and bleeding, and it can be a very big challenge to manage. If this is happening within the office, we're fortunate because we can put our suction on it, but clearing that and keeping that so that we're not forcing air in with that fluid into the lung. As we said before, we want to leave well-fitting dentures in place. Partial dentures, depending on their size, may become dislodged while we're doing artificial respiration. So we can leave them in place, but we want to be prepared to remove them if they become dislodged. We don't want to push them down into the lung. Now, looking at the respiratory anatomies, we have the nose and mouth, we have the pharynx, the oral pharynx, the nasopharynx, and then we have this thing called the epiglottis. And the epiglottis is like a trap door at the vocal cords that leads into the trachea. At the trachea, the Adam's apple, we have the cricoid cartilage, and just underneath it, the voice box, which leads to the bronchioles and the lungs. Now, respiratory ventilation is the mechanical process of breathing. It's the muscles contracting, and that's done, inhalation, actively. We have the diaphragm, which contracts. That takes ATP. So when we say active, we mean we need to generate energy, ATP, to do something. So we have the diaphragm, it contracts, and the intercostal muscles contract. The diaphragm moves down, the ribs move up and out, and we have a negative pressure. The pressure inside the chest is less than the pressure in the air, and the air flows into our lungs. Okay? Now, in normal ventilation, exhalation is a passive process. It requires no ATP, no energy. It just happens. As this muscle relaxes, you get elastic recoil. The diaphragm moves up, and the ribs move down and inward. The pressure inside the chest, then, is more positive than outside, and all of the air flows out. And we do that all day long, and we have enough energy demand to meet the inspiration. Now, respiratory physiology requires oxygenation of cells, though. Okay, oxygenation. So we bring the air in, but we still have to oxygenate the red blood cells and then travel cells around to oxygenate every cell in the body. If, when we're ventilating, we have inadequate oxygen, we call that hypoxia, not enough. And one way that could happen is by not ventilating properly. Another way is having the blood pulled elsewhere. And we're going to talk about what creates these problems in each of our emergency scenarios later this morning. But know that signs of hypoxia include change in heart rate, any altered mental state, agitation, elevation of blood pressure, and cyanosis. Respiratory perfusion is the actual oxygen-rich air entering the alveoli and the oxygen-poor blood in the capillary passing to the alveoli. The cells will give up their carbon dioxide to the capillaries, and the capillaries will give up oxygen to the cells. And then it'll start the whole process again. We all remember from basic anatomy, when we traced a drop of blood from the alveoli to the right finger, or from the right finger through the heart, back to the alveoli, and back to the head. We've all done that. And we have to think about what's really happening, because we have to identify the cause of the emergency and then do the treatment based on the cause. Okay, so remember that it's one thing if we're not ventilating. Well, then that's simple. We're going to do what? Positive pressure, mouth to mouth, bag to mask, ventilation. But if we're hypoxic and the patient's still breathing on their own, we're going to supplement their oxygen. We're going to add more oxygen. We're going to put the oxygen mask on them. And we'll talk about that when we talk about syncope. Now, remember that in children, and we've all experienced this when we've done our pedo bite wings or our 6-year molars, the mouth and nose, all structures, are smaller. The pharynx and tongue take up more space proportionally, right? Trying to check a kid's tonsils, it's hard to even get the tongue out of there. And the trachea is smaller, and it's more flexible. So we're not going to hyperextend. The cricoid cartilage is less developed and less rigid, and it's the narrowest part of the infant or child's airway. So we want to ligate anything we place into a child's mouth. The chest wall is softer, and infants and children tend to breathe more heavily from the diaphragm. When we open the airway, we can use a crossed finger technique where we snap it open. So patients lost consciousness, we want to open the airway before we're starting any positive pressure or anything to make sure we've cleared everything. We can take our fingers and open it. But remember, if we lay them back and do that, there's a chance that they could bite us. So be very careful. Watch your fingers. And you're going to inspect. You're going to clear. You're going to inspect for vomits, secretions, foreign bodies. You want to be extremely cautious with your fingers and the gag reflex, because if we get vomiting going and then we're trying to ventilate the patient, we can push the hydrochloric acid from the stomach into the lungs and burn the lungs. Okay? Use your suction, turn the head away, clear it all out. Okay, clear it out well. Now, we can use these oral pharyngeal airways, too, to keep it open. These are best used in like the semi-conscious or unconscious situation. These oral pharyngeal airways tend to cause some gagging, and but it does keep the tongue away. So if you were using a bag valve mask to positively pressurize someone, it keeps the tongue down and you can hold it down. They look like this. They come in different sizes. Most of us have a small, medium, and large in our offices only. You measure up how to use them by taking the corner of the mouth to the alley of the ear, from the corner of the mouth to the little tragus of the ear, the tragus of the ear. And that's about the size of the oral pharynx. Do you think about that? So you measure that up. This to the right here is a nasopharyngeal airway. And you can place it into the nose. You select the proper size, and you open the patient's mouth, and you insert this airway with the tip facing the roof of the mouth. So it would look like an S-curve going up to the roof of the mouth. You'd insert it below the circumvallate papilla and rotate it in. Now, you can imagine on a conscious patient, you wouldn't need to do this. You're only doing this for someone semi-conscious or unconscious, and you're trying to get their airway so that you can respirate them. Okay? The nasopharyngeal airway, rarely would a dental office use these. There's a lot of problems with them as well, because nasal polyps are so common and they can create bleeding, and then you've got a bigger problem in your airway. But they're used on patients unable to tolerate the oral pharyngeal. And you maintain your head lift, and you place it into the right nares, and you place it down from the nose into the pharynx. So diagrammatically, if we're inserting this, little hook goes up, and then once we get it behind the circumvallate, we rotate it over, and it holds the tongue down, and now we can ventilate that patient. Nasopharyngally, it would just go the same way and hold the tongue back, so that when we're placing our mask or bag on the patient, we don't have to worry about the tongue falling to the back of the mouth. Working with my clicker here. So this is the nasal one. It goes in the nose and then it's held here. And now you've got your head lift. You put your bag on and you can ventilate the patient. Now, intubation is what the EMSs people are going to do. And this is truly the way to manage the airway. Okay? What we're doing is basic life support. Once the physicians get on board, the EMTs get on board, or the hospital staff gets on board, if a patient's not breathing, they're going to intubate the patient. All of us that have been put to sleep have been intubated. Okay? They use sodium pentothal, or they use some kind of short-acting, what did Michael Jackson say, surgical now, propofol, to put us to sleep. But once we're asleep, they're going to maintain our airway by a tube, because it's the safest thing to do. So these tubes are sized, and they have a little balloon catheter. And what we do is we have a handle called a laryngoscope handle, and the handle fit on a little scope. And the scope is put together, and you take the handle and you move it down past the tongue to the epiglottis. I mean, we're past the oral and pharyngeal airway into the epiglottic area. We feed the tubes down with these little McGill forceps. And for those of you that have been in school recently, you recognize these from our medical kit, that we have these because we can retrieve things from the pharynx and oral pharynx with these McGill longer forceps, but they pass these tubes with them as well. And most people have different sizes. Typically, a little baby would have a size 3, maybe an adult female a 7, an adult male a 9, but they're usually sized up by the diameter of the person's baby finger, okay, to give you some idea. Your windpipe would be sized up about that level. And they're marked for how long they're going to go down into the trachea. And so if you think about this, now follow me down. We've lifted up this epiglottis. Here are our vocal cords, and we're going to slip that tube right in to the trachea. Right in. Now once it's in, we're going to inflate the little balloon, and we're going to make it fit snug. We're going to put that little thing there and make it fit snug. And now we can attach our bag, our face mask, anything, and we can ventilate that patient without any possibility of regurgitation from the stomach or anything entering the lungs again. So when we're using face mask alone, or mouth-to-mouth, or bag-to-mask, we are creating another set of scenarios where patients getting gas in their stomach, the stomach vomits, all that goes into the lungs, we burn the lungs. As soon as the EMS arrives, they're going to protect that airway. So our number one step when we take CPR, quick, activate EMS, because the sooner we get EMS, the better it is long-term for that patient. So primary on any of these little scenarios that you want to draw up for your offices, because in my experience, whenever I've gone to the supervising dentist, he says, well, go ahead, draw that up, and then if it looks good, I'll let you use that. You know, so if you want to draw it up, activate EMS is our first step, right? Let's get them on board. Let's get the patient managed correctly, because this is a much better airway than any of those other airways, okay? Much better airway. And airway management was something that the Ohio State Dental Board felt was very important, because most of the things that happen in a dental office, if we just managed the airway well and did CPR, the patient would survive and do very well if we just got that done quicker, okay? Got it done quicker. So, airway, activate EMS. If they're breathing on their own, you can assist it with oxygen. If they're not breathing on their own, you're going to ventilate them either with a bag and a valve mask, or you're going to use mouth-to-mouth or mouth-to-mask, okay, until EMS arrives. Now, next drug that's in the kit is epinephrine. Epinephrine is used to reverse hypotension, bronchospasm, and laryngoedema that result from an acute anaphylactoid reaction. Now, it can also reduce bronchospasm from acute asthma, okay? But it's a non-selective beta-adrenergic agent, meaning it'll have cardiac effects as well as bronchial effects, okay? Non-selective. Now, in our kit, it's supplied in either ampules or preloaded syringes, and we usually give 0.3 to 0.5 milligrams every 5 to 15 minutes. The most common ones we see are called the EpiPen, and there's two different EpiPens. There's an EpiPen for adults and there's an EpiPen for juniors, okay? The EpiPen for juniors is half their dose, and it's usually you use these up until half of the adult weight. So if an adult is average 60 kilograms per kilogram adult, we would use the adult. For a child up to 30 kilograms, we would use the EpiPen Junior. Okay? Now, many people are allergic to bee stings. They carry these around with them, and they have a little note. If you find me unconscious, what? Inject me with this. Inject me with this. So in an emergency, I don't know, what would your physician or your supervising dentist like you to do? Would he like you to pull that out and go ahead and inject them with it? I don't know. That's something you need to work with. But if you find someone laying on the ground, and that includes one of my sons, inject them. I'm giving you permission. Inject them. All right? So these EpiPens are preloaded, and they tell you right on them how to use them. And they carry them around, and the patients will have a little note around their neck or around their arm. If you find me, inject me with this thing. And there's a little thing called 911, and you take the caps off, you stick it in the leg, and you're done. Okay, you stick it in the leg, and you're done. I don't know, what issue, we have the little tester, you know, like so you can play with it. But I'm not sure every office or some of you had it when we were there, because they just started with this, and I think it's a great idea. I brought mine, and I'll pass it around so you can see how they work. But then you twist them again, and there's a second dose in there. Okay, so there's actually 2 doses, but you can only give one at a time, so you can't overdo it. Okay, can't overdo it. Now, pharmacologically, it causes a vasoconstriction that increases the heart rate, the blood pressure, and the force of contraction. So when you give this epinephrine, the blood pressure is going to go up, way up. Okay, it's going to go way up, and the heart rate's going to be full and bounding, right? And sometimes you have to give it to somebody that's already compromised. So you want to be prepared to do your CPR, but you've already activated your emergency response system, so hopefully you won't be in charge long, okay? Hopefully you won't be in charge long. Adverse effects, you're going to have arrhythmias, all right, and it may send someone into a cardiac arrest. But they'll die anyway. They'll die anyway, and remember that. You're helping. And it's going to increase the blood glucose, so they tell you not to do epinephrine if you're diabetic, but here we're going to save the person's life. Now, drug interaction. If somebody's already asthmatic, and remember that asthmatics are the people that have most allergies, right? So they may be asthmatic and in addition allergic to these things. In addition, allergic toxically to something. Those drugs will potentiate one another. It will be a higher blood pressure, more arrhythmias, because they're already on their substance medication for asthma, and then this. That's why it's very critical that we get the EMS activated. This patient may also need defibrillator. Another drug that's in our kit is Benadryl. Now, most of us are familiar with Benadryl. It's an over-the-counter drug, right? It's an over-the-counter drug. We take it, why? Why do we take Benadryl? We take it as an antihistamine for allergies, right? Antihistamine for allergies. And so it's a secondary line. It's not our primary drug for allergy. The dose is 50 to 100 milligrams, and it's used for itching, pruritus, urticaria, redness, erythema, and swelling. And we're going to take this and inject this, or give orally if the symptoms weren't too severe. In my particular practice, I would never ask my hygienist to give Benadryl. It's something that's a follow-up drug. There's no reason for her to be giving it. And why deal with anything by the time the EMS gets there? Let the physician go ahead and give the Benadryl and decide how to do it. But in an allergy, they will follow up with Benadryl. And Benadryl is not a primary drug because it's a competitive drug. It's a competitive drug. This drug will fill with